बिस्मिल्लाहिर्रहमानिर्रहीम। इय्याका नअबुदु व इय्याका नस्तईन। अल्लाहुम्मा सल्लि अला मुहम्मदिन व अला आलि मुहम्मदिन व बारिक सल्लम व सल्लिम अलैहि। Dear colleagues, I am Dr. Sultan Ayub, working as a radiologist. This is male patient, adult, almost 30-year age, with history of vague right inguinal region pain. So I am going to scan the right inguinal region, suspecting inguinal hernia with a linear high frequency probe. Now I'm going to show you the landmarks for the inguinal hernias, whether it is direct or indirect inguinal hernia. I have already told you about the landmarks. First one is we place the probe at the umbilical region. Here we can appreciate the shadow of the umbilical tissue. Then drag the probe inferiorly at the midline, just 2 centimeters below the umbilical region, and place the probe in transverse direction. When we have adopted such a maneuver, then put the color on the screen. We can appreciate this area. This is the rectus sheath, and this is the rectus abdominis muscle. This one is the anterior portion, anterior rectus sheath, and this is the posterior portion. This is the posterior rectus sheath. Place the probe in the transverse direction so that we have a broader area for scanning. The width should be increased, and the color box, when you put the color, lower the PRF up to 5-6, and the color gain should be increased up to 42. So that because at this area we are going to search the inferior epigastric artery, which is having the low blood flow, so that will be difficult to recognize, uh, and also it will take it will having the low blood flow, so very difficult to have a color. So for this reason, we should lower the PRF and the gain the and increase the color gain. So now I have placed the probe below the umbilicus. There should be right and left inferior epigastric artery. So the fellow is feeling pain on the right side. I'm going to scan the right area. So I'm on the right side below the umbilicus. So we are now going to scan we'll search the epigastric artery. Here, this is the inferior epigastric artery, which is very close to this one, very close to the posterior rectus sheath, and this inferior epigastric artery combined with the superior epigastric artery, which is the branch of internal thoracic artery, and this is the branch of external iliac artery. So when we trace the probe, when we have traced the inferior epigastric artery that is pulsating on the right side, then we drag the probe in the same direction in transverse position inferiorly. While scanning the patient, you have uh, copious amount of significant amount of gel spread over the abdomen so that you can easily slide the probe. Uh, so I'm again going to trace the inferior epigastric artery. Here we can appreciate this one. And now drag the probe lower down following this artery, which may show sometime color, which may not show sometimes. So you only look for the pulsating artery while dragging the probe lower and going slightly on the right side to reach the right inguinal region. This is the artery we can appreciate, and I am gradually dragging the probe toward the lower side. So now we have reached the inguinal region. This is the inguinal region, and these are the femoral vessels, and here there may be the inguinal ligament. So we should stay here superior to the inguinal ligament. And also we can appreciate this one. This one we can appreciate the vessels also, and this is the vessel also, and this is the vessel also. So these vessels are the spermatic cord vessel which are dipping into the abdomen through the deep inguinal ring. And this is the inferior epigastric artery on the right side, and this is the main point where the deep inguinal ring lies. So this is the deep inguinal ring above the inguinal ligament on the right side at the lateral aspect, and this is the inferior epigastric artery. And this is on the medial side, and this is the lateral side. So here this is the area of deep inguinal ring where these spermatic cord vessel dip into the abdomen through this deep inguinal ring, and this deep inguinal ring lies lateral to the inferior right side inferior epigastric artery. And here we can appreciate this one. This one, this is the internal oblique belly of the internal oblique, which is making triangle. So this whole area is the criteria. Number one, triangular shape of belly of internal oblique muscle, whether it is on the right side and the left side, and then the spermatic cord vessel dipping into the abdomen through this area, which is the deep inner ring, and the on the screen this one inferior epigastric artery. So this is the area which is the deep angular ring where the defect can be present if there is a hernia, and this defect is in the fascia transversalis that is lying posteriorly covering the deep angular ring. So I'm going to show you this from here to here is the deep inguinal ring, which is almost lower than 7 millimeter. Here it is 8.2 millimeter at present. So slightly increase in diameter. Uh, so here we have seen again internal oblique triangular shape just appear on the screen, spermatic cord vessels. These are the dipping into the abdomen through the deep inguinal ring, and this is the right inferior epigastric artery. and toward this side is the lateral side, and toward this side is the medial side. So here, if there is a defect at this area lateral to the inferior epigastricity, then it is the indirect inguinal hernia. And if the defect is on the medial side of the inferior epigastric artery toward this side, this is the direct inguinal hernia. So this is the one landmark if we follow the inferior epigastric artery of either side, right or left. So, and now I am going to show the another landmark which we can also use. So then again, put the probe just below the umbilicus where we see the rectus sheath. This one, this is the rectus sheath, and this is the rectus sheath anterior, and in between the anterior port and posterior rectus sheath, the muscle which is enclosed between the rectus sheath is the rectus abdominis muscle. So now the probe is in longitudinal direction. So then follow this muscle while dragging the probe lower toward the pelvic region at the midpoint, mid lower abdomen, below the umbilicus. Then follow this muscle while dragging the probe lower. Here, when we reach the pelvic region, we can appreciate the belly of the rectus abdominis muscle. This is the belly of the rectus abdominis muscle, and then it is inserted into this bone. Here we appreciate this one. This is the bone. We can appreciate in the screen this linear area with posterior shadowing. This is the pubic symphysis. And this muscle, this is coming, and this is the tendon, and it inserted into the pubic symphysis. So when we reaches here, then you just move the probe almost 1 to 2 centimeter laterally. So I have moved. So then we can appreciate that we cannot see the muscle, rectus abdominis muscle at this position. When the rectus abdominis muscle disappear while moving the probe toward the lateral side, then we can appreciate another bony segment. This is another linear area we can appreciate with posterior shadowing. This is also the bone. This is the pubic tubercle, 1 to 2 centimeter. When we reach here, then we tilt the probe toward the right anterior superior iliac spine as I am doing. So when you have tilted the probe at the right anterior iliac, superior iliac spine, well, the probe should be above the inguinal ligament. While doing this, you should ask the patient to empty the urinary bladder, because the urinary bladder will also displace the inguinal canal. So when we reach the pubic tubercle and and tilt the probe toward the anterior superior iliac spine, then we can appreciate the inguinal canal and supramatic cord. First, I am telling you another thing. So when you Drag the probe slightly laterally and tilt the probe toward the anterior superior iliac spine. Fine, I have freeze the image. Then you will only if you appreciate hardly all the this pubic tubercle is hardly visible, only the one corner is present, and then we can appreciate this area and this area. This is the anterior wall of the inguinal canal. This is the inguinal canal, and this is the posterior canal of posterior wall of the inguinal canal. This area, and this is the corner, and from here to here is the superficial inguinal ring. This wall will come here up to this. Here in the skin, it is not present. I mean, it is present, but it is not in the screen. So when here to here, this is the superficial inguinal ring. So this is the again anterior wall, and this is the posterior wall, and this is the area of the superficial inguinal ring. Now it is 6 millimeter. That is normal. Above 6 millimeter is uh, abnormal. So this is the superficial angular ring, and this posterior wall I have already told you. On the medial side, it is formed by the conjoined tendon. Already told you, and on the lateral side, it is formed by the fascia transversalis. So this is the area for the direct inguinal hernia, which lies medial to the inferior epigastric artery, and this is the inguinal canal. So I'm going to defreeze the image to show you in real. So here I drag the probe in the screen. It is the rectus abdominis, then is the tendon, then is the bone, pubic symphysis, move laterally, dilates or the muscle is disappear, pubic tubercle, and then uh, move laterally, just hardly visible, and then tilt the probe toward the anterior superior iliac spine. This is the inguinal canal, and this is the supramatic cord. And then when you drag the probe toward the anterior superior iliac spine, then follow these are the vessels of the spermatic cord. Here you can appreciate these are the vessels of the spermatic cord, and these are the femoral vessels. These are the femoral vessels. Keep the probe superior to the inguinal ligament. So when you appreciate these vessels are move laterally slightly, and then these vessels are dipping. You can appreciate into the abdomen through the deep inguinal ring. And then again, I have already told you this is the internal oblique, and this is the inferior epigastric artery, and this is the suprachoroidal cord vessel dipping into the abdomen. So this is again the uh, area of deep inguinal ring. So this was the second landmark. You follow the rectus abdominis, pubic symphysis, pubic tubercle, then tilt the probe toward the anterior superior iliac spine, and then you where these vessels dipping, it is an area of deep inguinal ring, and this is the inferior epigastric artery, and lateral to it is the deep inguinal ring. So this was the normal landmark. So I am now going to show you again Look here, this is the supramatic cord. It is हवा भरो. This is the we can appreciate here. Look here, this is the inferior epigastric artery, and this is the area of deep inguinal ring. Here we can appreciate the bowel loops are herniating through this defect. So there is a defect, and this is the inferior epigastric, where this is the medial side and this is the lateral side. So this defect is lying lateral to the right inferior epigastric artery. So this is the right-sided indirect inguinal hernia. Again, I am going to show you in the real image. हवा भरोसे ढीला करो, हवा भरो. Look here, this is the defect through which the segment of the bowel loop is herniated. ढीला करो, बोला हवा भरो. So we can appreciate here, and this is the inferior epigastric artery. You can see it. So this was all about the right indirect inguinal hernia. ढीला करो, हवा भरो जोर दी. So here we can appreciate. ढीला करो. So bowel loops are going downward into the abdomen when the wall salva is taken off. Bladder should be empty. So this was all about the right indirect inguinal hernia. Thank you very much. And dear colleagues, one thing I forgot to tell you, that when there is a indirect inguinal hernia, the herniated segment from the abdomen will move from the abdomen through the deep inguinal vein and then travel into the inguinal canal. This is the inguinal canal we can appreciate. So from the abdomen into the inguinal canal. While if there is a direct inguinal hernia, these abdominal contents herniated will move anteriorly upward toward the anterior abdominal wall like a bomb blast. These herniated contents will never move into the inguinal canal if there is a direct inguinal hernia. While if there is an indirect inguinal hernia, the herniated contents will move from the abdomen through the deep inguinal ring into the inguinal canal. Then they will reach the superficial inguinal ring, and through the superficial inguinal ring, These may go into the scrotal region or in the female groin region. So this is the main difference in the direct inguinal hernia and if there is a indirect inguinal hernia. So if there is an indirect inguinal hernia, the herniated content will move into the inguinal canal, reaching the superficial inguinal neck. While this will not happen in case if there is a direct inguinal hernia. For this reason, this is the main difference. If we so this we can see it in the sonography while asking the patient to have a Valsalva maneuver. I have measured the neck of the herniated hernia hernia and right-sided indirect hernia. This is 11.3 millimeter. So we should measure the size so that the surgeon need this diameter, and also we should measure the diameter of a sac and tell about the contents, whether it is a bowel loops or there is a fatty tissue or the omentum. So we should also tell about these things also. So this was all about the hernia, inguinal hernia. This is the right-sided and direct inguinal hernia. Thank you very much.